So, today's talk, thank you very much once again for inviting me and for giving me this really an honor to present before stalwarts of DGF. And I think maybe many of the things which I am going to say are very well known to all the members over here, but just to consolidate them all in one place, so to speak, and definitely open to having the questions and discussions and comments and suggestions, everything as we go. So, next slide. So, the first point that I really want to make is that we need to do away with the stigma associated with HPV, which I think is one of the major reasons why we face problems both in the sphere of vaccination as well as in the sphere of HPV testing. So we have to realize that it's a very common infection. It has been seen in various research projects that about 85% of women and 91% of men contract it at some point in their lives, but majority clear it, and we are testing cross-sectionally. So just because at the time we are tested we are negative does not mean that we never ever had that infection in the past, because it is a very stealthy, quiet infection. And it is nowadays often detected among women in their 30s who come in contact with a provider for treatment of infertility or STIs, or during routine screening where it is suddenly found that they are harboring CIN and the whole thing is being sidetracked. So enormous psychosocial and economic repercussions can be prevented by HPV infection, because no doubt that cancer is a rare outcome. Few people were going to get it, but a lot more people will be found to have the HSILs or the persistent infections, which require so much repeated testing and screening and triage and treatment in many cases, and all of this actually adds up a lot in terms of cost compared to what we claim is too much cost of the HPV vaccine. Next slide. So that is my message number one, is let us remove the stigma associated with HPV infection and cervical cancer. Next slide. So, of course, it is now well known that Harold Zurhausen is the one who found out this. You know, there was a time when HSV was being implicated, but the integration could never be shown. And he really went against a lot of dogma. I understand that he was even ridiculed in scientific meetings when he suggested this, but he was determined that his data was suggesting it, and he went on to show this and eventually got the Nobel Prize. But of course, Nobel Prize came in 2008. Before that, once this had been shown, there was already work to develop the vaccines and to develop tests and all of that. Next slide. So the first generation of HPV vaccines was developed based on 16 and 18, because there are more than 200 types and they are very tissue and species specific. So there are about 35-40 types which are affecting the anogenital canal, and about 17 types are being currently classified as oncogenic. So 16-18, which are 77% globally, are actually about 84% for India. So you can see that direct protection from these two type vaccines, like bivalent or quadrivalent, will itself give a significant protection. Then there is an extra protection of the cross protection, which will be there to some extent. This is, there are various theories about these types, whether this infection, this protection persists as well as does the 16-18, which are the actual types, whether it is equal in the single dose compared to the multi-dose, all of that. But notionally, yes, there could be protection for these types as well. No, please go back. And you can see, just go back to the last one, that the extra types for which the nonavalent offers protection from cancer is not so much. It is really in the space of get the CIN, where 16-18 is only 50% at that stage, where nonavalent has a real benefit. It is in the space of getting an abnormal HPV report, which has to be triaged, that the nonavalent is really beneficial. So yes, anybody who can afford the vaccine should take the nonavalent vaccine. But as a public health strategy, it is really quite all right to go with the 16-18, where our major focus is on getting the cancer cervix reduced. Next slide, please. So these are now various vaccines which are there already and others are in the pipeline. Cervarix, though it went off from the Indian market, is still available in some countries. We have Gardasil and Gardasil 9. Secolin and Waldenvax are the Chinese vaccines which are not available to us. And now we have Cervavax. So the three vaccines which are really speaking available to us. And these initial three vaccines, Cervarix, Gardasil, Gardasil 9, and Secolin, have been approved for single dose schedule by WHO. And for Waldenvax and Cervavax, these studies are still ongoing. And by next year, we will know about single dose. And meanwhile, their regular doses are fine. Next slide, please. So the first column really shows you the date at which they were launched globally and the date at which they were launched in India. And these are well known to you, the types and all that are being covered. A very notable miss in the nonavalent vaccine is actually type 35, which is very common in Africa, but which in our meta-analysis we found was actually common in South India as compared to North India, and probably next generation will include that as well. Next slide, please. So the second message I have is that the vaccines that we have are well suited to our requirements for prevention of CA cervix, because we do expect that with our 84% preponderance of HPV 16, actually mainly 16 and 18 together becomes 84%, and that is a fine choice to choose a quadrivalent for the national program. Next slide. So WHO has had this chart for a long time now, saying that you do the primary prevention in the girls before the infection comes, and infection rates are maximum in the third decade of life, soon after they become sexually active. But this age of sexual debut varying in various countries, and even in ours, we are really not sure. The NACO data suggests 17 as the median, but we get reports of even earlier, and we know about how many teenage pregnancies we have, and especially in rural areas. So the age, definitely when you give a 9 to 14 before they are sexually active for sure. And also there is a much brisker response in the immune system for any vaccine at that age. The secondary prevention, because the cancer really begins to rise only after 30 years of age. So as a universal strategy and a cost-effective strategy to deal with all the infections and minor changes which would have self-cleared before that. So 30 years is the recommended age by WHO and by our own country as well. And then of course there's treatment. Next slide. So all this changed in 2018 when Dr. Tedros chose this as his sort of, the mission for his tenure, and didn't know at that time, of course, that a pandemic was coming. And fortunately, it had already been declared. The marvelous thing was that despite all the urgency of COVID, these talks also went on simultaneously. We had these long 4 or 5 hour calls through the pandemic, and we had this rolled out in 2020, November 2020, and 194 countries being signatory to it, including India, to implement this hopefully by 2030. So now that's very, very close, that 2030, 90% of girls to be fully vaccinated by 15 years of age, but still the more doable strategy as compared to 70% of women to be screened with a good HPV test at 35 and 45, and 90% of those to receive treatment and care is still the more difficult target. And today we are talking about this first pillar of this approach. Next slide, please. So this was our meeting on the sidelines in 2018 when it was declared, and FIGO say we had expressed our complete solidarity with the WHO call and had a side event at that time when Dr. Purandare was the president, and I was at that time chairing the FIGO Oncology Committee. Next slide. And then the strategic advisory group of experts, which is WHO's wing for looking at all immunizations in general, and we have a working group for HPV vaccine, and that looked at all the data that was coming out till then. Of course, the randomized control trials were few, and the quality of the data, including our Indian trial, which had been stopped midway, and had become a good observational trial because it was randomly stopped, an RCT that was randomly stopped. And many of the data that came like from good quality trials like ours informed decisions even in countries like UK to switch to a one dose. But also there were countries who were implementing two dose who were reluctant to switch to a one dose in case there was a need to switch back to a two dose. So a one or two dose option was given by WHO. There will be a SAGE meeting again in the end of July to review the current data because a lot more studies have come now, because our study has been like a like a proof of concept type of thing for many RCTs after that. So let's see, maybe this one or two, which always confuses everyone and rightfully so, may hopefully change to a one dose firm recommendation by then. But our study in India was till 18 years of age. There were others till 20 years. So the one or two dose option was extended right up to 20 years beyond the primary target cohort as well, and two doses after that. In this recommendation, 3 doses are only reserved for the immunocompromised individuals, including HIV, transplant recipients, autoimmune disorders, etc. And at least minimum 2 doses they should get. There is no recommendation of a single dose for this group of people. Next slide, please. So how does a single dose work is the very big question, because when this vaccine started out, all immunologists, vaccinologists believed that a vaccine of this type does require 2 additional boosters to make it valid. And it was only because situations emerged that allowed this to become a single dose. And a lot has been looked into this matter, how it works. So of course, there are the neutralizing antibodies which prevent HPV from binding to the host cell. And the upper one shows how the HPV comes in, goes to the basal layers, and then goes through it, integrates with the DNA, and it's comes out in the episomal form or in the integrated form eventually. And how, if you have a high antibody in the lower left, if you've had multiple doses versus you've had a low antibody, which is a single dose thing. And they find that there are other mechanisms by non-neutralizing antibodies that work, including antibody-dependent phagocytosis, neutrophil activation and degranulation of antimicrobial proteins, and antibody-mediated clearance of infected epithelial cells by cellular cytotoxicity. So because all these mechanisms act for HPV vaccine, it has been not possible till now to have what is called the immune correlate of protection. This is well known for most childhood vaccines, including you've seen we get our rubella vaccine titer checked. Are we not immune to it? And if it is not, then we give another dose. Now, this titer has still not been determined for HPV vaccine because only neutralizing antibody is not the mechanism. And even very low levels of antibody do seem to work in terms of efficacy. Next slide, please. So these were the recommendations that INTAGI came out with after the WHO recommendation. And ever since then, of course, we have waited even more actively. And I must tell you, having been and still am a member of INTAGI, that it was looked at very thoroughly as to what is the cost effectiveness and all that. In fact, I was a bit annoyed at that time, and I said, you never do this for any vaccine, pediatric vaccine, because you are all pediatricians and you know this vaccine is desirable. But now for HPV vaccine, you started this new thing. So much time went in that cost effectiveness analysis, everything. But in a way, it's good that we've got all that behind us. And we have firm reason from NTAGI to say that yes, this vaccine is a required vaccine and will do good for our country. And they had recommended that we should have single dose of the existing vaccines, and Servavac we should have the trial for showing the single dose, because WHO requires that you demonstrate persistence of the antibody up at 2 years. So, in fact, that 7 months before, 6 months before the second dose was given, the titer was checked and found to be fine. But then they were all given the second dose, so there was no one dose group in the initial trial. So this study, ICMR started at 3 of their own institutes, and they finished recruiting in March of 2025. So March 2027 is when the data will be finally, I mean, the last samples will be taken, and by the end of 2027 is when you will really have the data regarding the one dose. And the government is rather reluctant to have this 1 or 2 dose, because it's a huge machinery, and once you get the message down to the field workers as to how it is working, and then to change that becomes more of a cumbersome thing. So the government is keen to have a single dose if it is feasible and reliable to do so. Next slide, please. So I told you that basically we've had some good studies, and I'll start from the right side actually. In this case, the Costa Rica HPV vaccine trial was the initial trial of the bivalent vaccine, large number, 16,000 plus girls. And they saw that there were some dropouts who still had comparable efficacy when they had 1 or 2 doses. And this served as proof of concept for our trial in India, which was started in 2009, comparing 2 versus 3 doses of Gardasil 4. And this was stopped when there were problems in the PATH trial, nothing to do with our trial, but abruptly all recruitment was stopped, which left us with almost equal numbers of single dose, 2 dose at 2-month interval who didn't get the third dose, 2 dose at 6-month interval who were the 2 dose group, and 3 dose, of course. So this was very interesting, and it was good that Gates agreed to follow it up and found that there was indeed not just immune titers persisting, but also efficacy persisting. In fact, this has now become the longest running single dose. So a very good sized 4,000 size cohort, and this served as proof of concept for others. Now, Doris came up in Tanzania in 2017. Now, what they did was to measure the antibody levels with single dose of Gardasil 9 or Cervarix, but they actually compared them with the CVT and with the IARC studies. So it was not, strictly speaking, anything randomized comparison. So Kenshi was probably the first one that really looked at it in a randomized way. They did Gardasil 9 and Cervarix, and they found 98% efficacy for up to 3 years post-vaccination. But there, I must say, many people say only 3 years, 4 years, but it's more or less a plateau, and that's how it is for most of the vaccines. So one has to sometimes have a leap of faith. You can't just wait for 15 years to watch the data and then decide. So you do have to take a decision based on what it appears will be the case, and most of them are plateaus and don't need. And same thing we have seen in hepatitis vaccine, where we initially thought a booster will be needed but was never needed subsequently. Next slide, please. So this, what I'm showing you, is basically our trial report in a monograph which came out from the Journal of the National Cancer Institute in November 2024. It's a whole monograph devoted to single dose studies from around the world. It is free access. And as I said, ours is now the longest running follow-up of 15 years, basically. And it is looking at the vaccine efficacy amongst that unmarried girls 10 to 18 who were vaccinated and then followed up after marriage and pregnancies and all that. And we're still continuing to follow. And now Gates has agreed for an extension till 2028. So from, you can see from the initial vaccination starting in 2009-10, that's going to be a really good, nice follow-up, as had been already envisaged, the 20-year plan. And so we've compared them with an unvaccinated cohort that was recruited post hoc. So yes, the limitations of not being randomized, but at the same time, it has shown that with a single dose, there's high protective efficacy against persistent HPV 16-18 infection and associated neoplasia. And of course, the data is still accruing. Next slide, please. So this served as proof of concept, as I said, for many studies. And the most interesting now has been the Escudo, which has been done with the bivalent and non-valent vaccines. Again, a very extensive trial done in Costa Rica, which has looked at girls 12 to 16 years of age who got 1:1:1:1, either 1 or 2 doses of the bivalent, or 1 or 2 doses of the non-valent. And the primary endpoint was the new and persisting HPV infections. And it was seen that 1 dose was non-inferior to 2 doses. The vaccine effectiveness was at least 97% in each of the 4 trial groups. There were no safety concerns that were identified. And this is the very recent data which came in December, which led to the CDC also adopting a single dose schedule. Next slide. So here you can see what is the status in August 2023. I told you in 2022, the WHO had agreed that you could do 1 or 2 doses. Now you see in orange the countries which had moved to a 1 dose in 2023. Foremost amongst them was Australia. Of course, they had launched the national program back in 2007. Just one came into the market, and mainly because their prime minister's wife came out openly. She had been to Singapore for some cancer treatment, it was known, but after the vaccine came, she came out and said, I had cervical cancer and no girl must suffer cervical cancer. And she fast forwarded and fast tracked the whole system to put this from 2007. And UK also 2008, they had the vaccine. They initially had bivalent, then they had quadrivalent. So these are the few countries at that time, 26 countries, which had a single dose. Next slide. Now you see, this is WHO, HPV dashboard updates in real time. And this was the status on 8th of January. This is before our launch, right? 8th of January, and you see how many changes was the USA had moved, Canada has moved, most of South America, most of Africa, but not just the countries which are Gavi countries and all, but many other countries have decided here. So already 89 countries were now on the single dose by January this year. Next slide. So the conclusion I have as a third message is that the national and state programs have to focus on the primary target age group, which is under 15 years, and single dose recommendations apply to this group and up to the age of 20 years. Next slide, please. So on 28th February, of course, was the absolute watershed moment for us when finally we had the launch of the National HPV Vaccination Campaign. So I have to tell you, as the chairperson of the technical expert group for launch of HPV vaccination in the ministry, we were following this up right from May last year, when the first tranche of the vaccines from Gavi arrived, 100,000. And it had been agreed that while we are waiting for this single dose data to come, we can start off with this, which will give us an opportunity, of course, to catch the 14-year-olds who would be out of the cohort by then, and also to give us a lot of lessons on how we are to do it, and what is the strategy, what are the advantages, disadvantages, etc. And we were waiting since June last year for a date for the launch from the Prime Minister's office, and more vaccine tranches were coming, more and more states were being covered for training. And finally, when it did happen, all the states had been trained, all the vaccines had been given as per cohort size already distributed. and a national launch. So it's actually the first vaccine that was launched by the Prime Minister and the first vaccine to have a simultaneous nationwide launch in the country. None of the vaccines so far has that ever happened before. And I think it does take away a lot of the problems of wondering why the state, why not that state. Everybody is in it together. Next slide. And so this was a proud moment when the WHO dashboard showed us also in green. China had turned green, dark green, I mean, back in November when they had rolled out their program, and a lot of people from WHO had been saying that till China and India get into the vaccination mode, we won't have global elimination because they contribute so much of it. So here was the situation where ours was also launched and we became the 161st country. But in terms of size, this was really, really important. Next slide, please. And here you see other aspects. It's a very interesting data the dashboard, which you can see in the bars on the top. It will tell you the introduction status, year, delivery strategy, targeted sex, the coverage with the first dose, the complete coverage, the schedule interval, etc. So here you can see that now we have 91 countries which are at one dose. Then there's still only one now who is doing 2 doses at 12 months. Previously, it was also being done in Indonesia, but they have now switched to the single dose. Then 2 doses at 6 months are a large number, which are 70. But the majority now is with the single dose. And this shows you the primary delivery strategy, whether it is facility-based or school-based. And you see that the majority, can we go back, are school-based. And we have deliberately, can we go back, go to the next one, the delivery strategy? Yeah, the majority are school-based really, about 90 countries. And then there are some which are mixed as well. But we consciously have chosen the facility-based approach because there were concerns that there may not be adequate information to the parent and they may not have actually signed the consent form properly, or some states don't even do that. They just send a message in the bag, and if the child comes to school the next day, it's assumed that the parents agreed and stuff like that. So it was decided that having it in the facility, making the parent bring the child, an opt-in approach, so to speak, would be better than the opt-out approach of school vaccinations, and would do away with the concern that they are not having the voluntary consent being taken. Next slide, please. And this shows you about the female only versus both sexes. And you can see that there are a larger number who are doing both sexes now than the female only, which is really more restricted to parts of Asia and Africa. But then this is a totally economic consideration where you have large numbers of girls waiting. You don't want to yet give it to the boys. And most people who have gone both sexes have done it after having initially launched as female. So by and by, yes, but where the boys can afford, definitely it's a very good idea to give it to them. Next slide, please. So coming to our own vaccination strategy in the national campaign, it is Gardasil quadrivalent, and it is the difference in the vaccines which have come for the public program is they have these BVM30, what is called a vaccine vial monitors, which show you for each vial that the cold chain has been maintained and it is fine to use. And BVM30 is the one for the more heat stable vaccines. And it's been received through a Gavi partnership. Next slide. Just a couple of slides about what Gavi is about, which has caused a lot of concern also amongst the anti-vaxxers, that this is a Gates Foundation driven thing. But there are a lot of partners. There's UNICEF, there's World Health Organization, World Bank. There are the implementing country governments, the donor country governments, civil society organizations, research agencies, vaccine manufacturers, and private sector partners. They all come together. It used to be called the Global Alliance for Vaccine and Immunization. Now they like to call themselves Gavi, the Vaccine Alliance, whatever reason. Next slide. And then Gavi procures this at a price of about $4.50. The UNICEF handles the purchases and finances eligible countries. So every country contributes also. India also pays some amount to Gavi as a donor and receives, of course, far more. And it will be vice versa for more affording countries. So there are various technical partners which help to introduce the vaccine, and it includes, for example, JSI. In our case, John Snow India is the one which has been doing the trainings across the country, right down to the grassroots levels. And there are various other partners. Next slide. So the campaign duration is for 3 months. And during these 3 months, there will be daily availability of the vaccine. After that, it will be only on the routine session days, which will be decided which days those will be, but at the same health facilities. And all girls who have completed their 14th birthday, not yet celebrated their 15th birthday, but during the campaign period, those who are celebrating their 15th birthday can get the benefit up to 31st May. And these 14-year-olds are roughly 1% of the total population, so about 1.15 CR. And of course, some of them may have already been vaccinated either privately or through the various programs which so many of our gynecologists have been facilitating. Next slide. Now, who is exclusion? So out of target age group, basically who are not yet 14 or more than 15, if they are already pregnant, previously vaccinated with any vaccine, even one dose, and you can capture the status in UWIN even now. Now, this prior severe allergic reaction to the vaccine or if any of its components, so this has also recently been blown up by the anti-vaxxers about yeast allergy, and you must test for yeast allergy before you prescribe this vaccine. But fact of matter is that yeast is used, for example, in Engerix B also, and nobody's ever had to test for yeast to give it to them because it's a very rare situation. And even now at the last count, there were about like 40 adverse events reported at the point when it was 3 lakhs, so proportionately maybe more now. And none of them are serious. And there were a couple of girls who had some degree of urticaria, but nothing really more than that has happened in all this mass vaccination that we have witnessed in the last few weeks. So of course, if anybody is moderate to severe illness, you should postpone till they have recovered. Next slide. So all the government health facilities can keep this, but they may not always be available. So the best thing is that when they go to UWIN and they register on that and they put in their PIN code, it automatically directs them to the nearest facility which has the vaccine and gives them an appointment for it. And there's a whole team of vaccinators, mobilizers, verifiers, volunteers who are involved in this. So you can imagine that the training has been rather comprehensive to bring all these people into the fold and to give them information about what we are doing. Next slide. So this is the link to access the operational guidelines which are up on the MOHFW site, and you can get all details about the operational guidelines for rollout of this HPV vaccination campaign from that. Next slide. So if we look at the scenario or the progress so far and take a step back to see what it means, there's about 500 million doses that have been administered worldwide since 2006. Here it was approved in 2008-9 basically. We've had about 4 million doses being administered in India, 40 lakhs. Majority of these have been administered in the 2 or 3 dose kind of format. So it doesn't really mean 40 lakh individuals. Compared to that, we've seen over 12 lakh doses already done pan-India in 5 weeks under the national campaign in a totally voluntary setting. The health workers have been explicitly told that they must not go out to coerce people, merely spread the awareness. So it's been a fairly large coverage. I've seen people saying only 10% and all, but you know, it's really a fair number that have been done, and the rate is increasing because there were a lot of holidays and exams and all of that last month. Some states were not yet ready to launch. So given that, I personally feel that it's a great response, and it can be better, of course, but it's really pretty good. And as I said, no serious adverse events have been attributed so far in this large number of doses. There have been so many unfounded and baseless concerns about fertility, autoimmune, and other effects that will come in the future, which are totally baseless, because if you think about it, how many women have conceived globally and even in ours? So, in fact, we got a lot of videos from our girls who had conceived. MP has been the leader, but one Saturday, and I was sitting in Bathinda when the ministry persons, Dr. Pawan, said there's a lot of pushback in MP, and all this data and all is not appealing to anybody. We need videos from the actual girls. And I was like, I'm in Bathinda, it's Saturday afternoon. From where am I going to give you videos now? Maybe Monday. But I just messaged the girl who is our A&M, who keeps in touch with these girls, bring them in. Many of them, in fact, have delivered at AIMS, keeps in touch with them. And within hours, 2-3 hours, she had already sent me half a dozen videos. And some of them were by girls who you would not imagine can actually record and send. Some of them, of course, very well educated and all. And then I said, take a permission. She even sent a message from them that you can use my video and you can show it anywhere. The girls who couldn't do it had sent voice messages. It was very encouraging. There are so many girls. We have looked at fertility. We have looked at abortions, preterm labor, stillbirths, congenital malformations. And there is nothing that we have to worry about, even in our own experience, leave alone the globally reported literature. And or kuch nahi to ab now the yeast allergy started off, which is so, it's so strange that people should want to do it, as you all were discussing at the start of the meeting. Next slide, please. So here's the message I have, is that our gynecologists can play a very important role here now to answer questions and concerns from parents, educate teachers, journalists, etc., and address the pushback with positive data-driven messages and messages from own personal experience. Next slide, please. Safety is well known. There's been lots of data on safety. CDC once said that the vaccine is as safe as the tetanus toxoid because there's no increase in adverse events over the rate which is in the general population. Next slide. In fact, we compared the adverse event profile of Cervavac versus Gardasil, which was the Cervavac censure data. And the cohort 1 was the ones up to 15 years of age, and the cohort 2 were the ones up to 26 years of age. And it was really very safe. What was very interesting was that the boys and men had a better tolerability for both the vaccines as compared to the girls who experienced more pain. That was a very interesting finding in this. And I have brought, next slide, because many people have worried about the ovarian insufficiency. And it has been a systematic review and meta-analysis has been done comparing the quadrivalent vaccine with the bivalent, with the nonavalent, and with other childhood vaccines. And they find that there is no increase. Risk of POI after HPV vaccination is relatable to worldwide incidence, giving reassurance about safety. After all, everything that now happens will be after vaccination, never can be before, just as everything used to be after tubal ligation and all the problems ascribed to that. Next slide, please. And this is the efficacy, which we well know, CIN2 plus with 16 and 18. All studies have shown it to be beneficial. Next slide, please. And because people say that CIN2 is not really about the cancer, next slide. So we say, next slide, that the real world evidence, because you cannot leave a CIN2 untreated. Next slide. You can never have cervical cancer as an outcome measure in a randomized trial. So you have to see the real world data for that. Next slide, please. Next slide. And the first real world data that we had was really on the high grade cervical abnormalities, which had come so far back from Australia, which had shown that the girls under 18 years really had the maximum benefit in terms of vaccination. Next slide. And then we've had analysis from the very good Nordic registries, which have shown from Sweden that the unvaccinated compared with those who were under 17 years or those who were 17 to 19 years, and they have seen that under 17 had an 88% reduction in the cancer rates, and the over 17 had a 53%. So even they had benefits, even 17 to 30 years vaccinated. Next slide, please. And then you had this from the UK, which is basically in the period which they had received the bivalent vaccine. And they found that the estimated relative risk reduction in CA rates was about 87%. Again, quite consistent data for the girls who are 12 to 13, vis-a-vis the 14 to 16, 62%, 16 to 18, 34%. And the CIN 3+ rate reductions were even a bit higher than that. Next slide. Next, yeah. And this one again from Denmark is showing similarly. So this is the reason I have been now saying that we see these benefits even in girls up to 16, 17 years. And our donor programs, now that the government has started up to 14 years, we should target girls who are 15 to 17 years to catch up those who will not get the benefit of government programs. The impact evaluation of the Australian HPV vaccination program also showed that the single dose had equivalent protection, as you see in the third column, compared to the 2-dose and 3-dose, and about half of that compared to the unvaccinated. Next slide. So that's the message that HPV vaccine is safe and has proven efficacy in protecting against cervical precancer and cancer in real world data shows us. Next slide. And so my key takeaways are that this is a powerful tool we have in the battle against cervical cancer. All the available vaccines are safe, effective, and immunogenic. The primary target group is girls under 15 years, but you can give single dose up to 20 years. Vaccination of boys should be encouraged where they can afford it. And all 14-year-old girls should avail free HPV vaccination under the national campaign. So thank you very much, and my apologies for going over time. But really, if there are any questions in the chat box or directed personally, I will be very happy to answer them.
Thank you so much, ma'am. I request Shadajan ma'am to please.
I think, after Dr. Bathla speaks, there are no questions left. And I think she has tried to answer each and everything, and each one of us knows the whole story about HPV vaccination, how it has evolved, and how India has contributed greatly. And we have a great honor that Neerja is the face of HPV vaccination in this country, and if she speaks, I think all questions are taken care of. And I'm very glad that in a time of just 1.5 months, so much vaccination has come, and they have come voluntarily. That is something beautiful about it. And in spite of the exams which are going on, I think it has been a great response. At least people like me, never thought there would be cervical cancer Mukt Bharat, but looking at it, it looks, that it will be a reality. I have one question to ask Dr. Bathla. As an expert, what is your projection if everything goes well and we also pick up in screening part, which we are lacking far behind? When is the likely time that the country will be cervical cancer Mukt?
Ma'am, the modeling suggests that if we do by 2030, if we get to these goals, then the projection is 2062. We will be at that goal of 4 per 100,000. But since we are not looking like, I hope we will. We've got a HPV screening test also of TrueNat is now been validated, has been approved in the HTA of ICMR. And Dr. Paul is rather sensitized towards it. So we may actually be able to roll out HPV screening also in our program very soon. And if we can do that, then we can definitely hope by maybe 2070 or something, realistically speaking.
Another question, Dr. Bathla, a state like Bihar offered 10 lakhs vaccination from Sarvavac from 9 to 14 years. What is the expert guideline for that particular vaccination? There are 2 doses or there'll be 1 dose?
So, we had in fact even brought out a paper suggesting government could consider a delayed second dose with Cervavac, because there are countries like, in Canada, they had suggested doing the second dose at 5 years. When it was a 3 dose versus 2 dose, they suggested 2 dose and third dose at 5 years, and then they never needed to because the data came. And in our trial also, we saw that up to 18 months, if somebody got it, then the rates were similar. The levels were similar compared to getting at 6 months also. So a delay doesn't do any harm. If anything, it's a little bit higher only. And so the suggestion was that you can consider giving a single dose of Cervavac, and provided you can track the girls, you can tell them that we will give you the second dose after 3 years. Meanwhile, by the end of next year or by 28, you will get the data. You will know. Likely it will work as a single dose and you won't have to go back to them. And if it doesn't work, then you can go back and give them a second dose later on.
This is exactly the feedback I got. This is exactly the feedback I got. They said that they will be giving a single dose, but they will given an undertaking to them. The booster will be required, may be required after 3 years.
Yes, yes.
But it all depends upon, what the expert group feedback.
So as of now, this WHO pre-qualification is required to be a Gavi vaccine, which Serum Institute is working on. They have submitted their dossier and they got back some queries and they are working on it. Once they get licensed, they will also be on that Gavi eligibility list, and they may also come through Gavi. But right now, because we had this option, and then the way to do it in which you can, keep the supply chain going for the next couple of years with this 2 dose, and then to give it not to all the girls. So in some states, 9 to 14, like, states like MP and Andhra, which are doing so well, there the 9 to 14 will get vaccinated. In some states, the 14 won't get it at all. So it was decided that we just do only 14 so that all these girls get the benefit and don't get phased out.
Thank you, ma'am. Shada ma'am, there's a request if we can postpone the second talk and we can take all the chairperson's comments and discussion in this talk.
There's so many queries, we can postpone the second talk, and so many people have so many queries. So I think those queries must be sorted out. I also feel this.
I have the chairpersons for the second, Dr. Jyoti Bhaskar ma'am, Dr. Deepti Naam, Dr. Sunita Arora, Dr. Vandana Gupta, Dr. Leena, and Dr. Jyoti Bali. They all have joined. So we can take comments from all the experts. Manjupuri ma'am, you would like to add on to this?
Yeah. So thank you, Dr. Neerja, for updating us on whatever was the story of HPV vaccine. My question to you is that what is your opinion on screening for people who are not married and not sexually active? Not sexually active, not married, but not sexually active.
So if they are not sexually active, I don't think there is recommendation. There is a possibility of getting HPV infection even through, some digital contact or heavy it or whatever. But it is really a very notional thing. And if they're absolutely not, then I don't think there's any significant recommendation. Now, having said that, they have done some study recently where they even found that in nuns also they are seeing infections outside somewhere. There's a possibility that before they entered the nunnery, they may have already been exposed or something like that. So that is the thing. But truly never been sexually active, the risk of having the infection is very, very small. Now, of course, with the HPV swabs, it's very easy to take even for those who are not sexually active, to put in that very fine swab and take it. But it is not really seriously recommended.
Thank you. And the swab thing, I'm to say that is now accepted method for putting in the swab in the vagina, self-sampling.
going to do a position statement for Foxy also, the recommendation is that if the self-sampling is to be repeated every 3 years, the clinical sampling is to be repeated every 5 years. So there is a little bit of disparity in that respect, but it's a good method.
Thank you so much. Thank you so much.
Thank you, ma'am. Dr. Meenakshi Ahuja, ma'am, I will request you to stay back and please join us as an expert, ma'am. Ma'am, would you like to add on to this? Meenakshi, ma'am?
You'll have, so good evening. As always, really enlightening to listen to Dr. Neerja. I have a very different question to ask. So many patients of us, obviously, we are more concerned about girls' vaccination and all. But considering that you are in the research and you get to know about this, is there anything being done about how to test HPV in males?
So, that has really been done only in research studies because the male genital area is so vast that to really sample it adequately, it requires it's a very painstaking
Or
method.
oropharyngeal swabs or something?
Oropharyngeal can be taken, but oropharyngeal in India actually is much less by HPV. In HPV, oropharyngeal is still tobacco driven. There is not a very big component of oropharyngeal caused by HPV.
Bhargav, ma'am, are you there, ma'am?
Raka?
Bhargav, ma'am?
We wait for Dr. Bhargav if she's there.
Is there?
Dr. Bhargav, is she connected?
Am I audible?
Yes.
Yes, ma'am.
You see, the lecture has been given by such an expert that over and above that, I've got nothing to ask. Because my knowledge is only as far as my experience is that from my OPD patients. I'm not doing any public work, so I cannot really say what else is to be done.
Thank you, ma'am. Thank you so much, ma'am. Your presence and expertise we have all learned from you, ma'am. Thank you, ma'am. Raka, ma'am.
Well, thank you, Dr. Neerja, as always, for an enlightening and very informative lecture. I just want to ask you one thing. Like in our OPDs, fine, we've captured the younger generation and everything, but we still get ladies at 30, 32, 35 saying, do I need the cervical cancer vaccine? I have not taken it before. Should I take it? So what is your take on that? Should we advise it or should we tell them, no, it's not required for you?
I realized that this program was about adolescents, so I removed all the parts about that. And tomorrow
I'm sorry, I'm asking you this.
No, it's fine. And tomorrow I'm doing one for IMS, so I thought I will restrict the midlife part to tomorrow's IMS session. But it is fine. It is actually fine to take it after and postpartum vaccination and older age group vaccination. But what I've just typed in the box also is that there have been studies that suggest that most of the ones who got cervical cancer actually got their infection by age 30. So a lot of women have already acquired that infection, which is going to give problems, at least 60 to 70% of them. And therefore, it will not be beneficial. It should not give a false sense of security. So it may be beneficial, it may not be beneficial, it won't do any harm, but it does not replace screening. If we can get these messages across, then it's all good. Now, having said that, somebody highlighted, and I really need to get that data and put it into my talk somewhere, that NACO has looked at patterns of sexual behavior. They look more closely than anyone else, I guess. And there's actually, I believe, data. Now, this I'm just suni sunai baat. I have not really read this myself yet. But they say that the patterns of sexual behavior are so different in India compared to global, where global, they have multiple partners in their youth, and then they kind of settle down with somebody. Whereas in India, they don't have multiple partners in their youth, and they have all these dalliances later on. So that if that is the case, then really our women need to protect themselves. And they need to be taking the vaccine. So I think broadly the thing is that if anyone's asking for the vaccine, absolutely fine. Go
Just
ahead
give it
and
to them. Okay.
Give it to them. But just make sure that they don't think that they don't need screening because they got it.
All right. Thank you.
So it's a matter of fact we should stress more on screening those women rather than giving a vaccine. I just wanted to say another thing. We did one genotyping study in our institute that was, of course, PCR based. We found 46% had 18 and 16. Rest were other types. So
No,
we are
but
getting
this is
other.
what? This is in the screening population.
No, it was, yes, it was
In
in the
cancer.
screening population. Exactly.
Yeah. See, in the screening population, in fact, that's very high, 46%. It may have been your colposcopy clinic or something. Because
we have that
actually,
also.
it's only about 7% in the population, normal population. And Xavier Bosch would say that they are like race horses aligned at the start of the race. And then the 16, 18 get way ahead because they are the more aggressive ones. So when you see the normal population, 16, 18 is only about 7%. Then you see the CIN2, 3, it's about 50%. And then you see the cancers, and they are anywhere 77 to 84%. So they get more and more. So as I said, giving the non-availant vaccine helps you to not get that abnormal report, because at that stage, a lot more are present. But if in CIN, again, you will get more of 16, but in cancer. So from cancer perspective, 16, 18 ko deal karna is fine. But to deal with CIN, because we don't have that good triage strategies yet to really pinpoint that ये CIN किसके कारण है या ये infection किसके कारण है. तो if CIN 1 है और वो कुछ 52, 56 है, likely वो clear हो जाएगा खुद ही. But we don't know that at this time for a fact. So that is why
hospital-based. It was a hospital-based study, and they don't come without any symptoms. They have some symptoms. Yes.
So that is perfectly consistent.
Thank you, Dr. Neerja, for giving such a wonderful insight into cervical cancer vaccination. But the government hasn't come up with any vaccination plans for the boys, so that herd immunity may be better looked into.
So herd immunity, they say once you get more than 70% coverage, then herd immunity kicks in. They found this in Australia already. But in Australia, when they found this very early, that when they followed in the sexual STI clinics, they looked at the rates. They found that the rates of aborts they took as the first surrogate. So the aborts declined in the girls and in the boys as well, who are heterosexual, but not in the men who have sex with men. And they looked at various sexual transmitted infections and found that the others were still at the same rate, but the HPV related had declined. And in men who have sex with men, they had not declined, which is when they decided that they are going to include the boys in the program, because the boys don't know at that age whether they are MSM or they are not MSM. And we are very far from all that yet. And that's the secondary part. But as herd immunity goes, they say if your coverage is less than 50%, then it's important to vaccinate both from the perspective of herd immunity.
Herd immunity, yeah, that would be, because covering only girls, I think we are not going to be able to cover 100% girls. So,
no, but the results are very good in Sikkim, Bhutan, and all our related things. They have managed to cover, even in Punjab, and they did in a similar way. They did in community, but they informed in schools, and they took class 6 girls, and they covered 92-93% of the girls by that method.
Okay, thank you.
So let's see where we go this time.
Yeah, hopefully.
Renu Mishra, ma'am.
Thank you, Neerja, for reinforcing that one dose is enough, because still a lot of gynecologists are don't feel comfortable, because the company leaflet still recommends 2 doses. So, and probably the DCGI also. So, although we have been giving 1 dose since you told us, after the AIM study, but it's nice to sort of have data now to show efficacy and safety.
So, the company is right in what they say, because they have to go with their recommended manufacturer's recommendation, and the DCGI basically does it based on the data which has been presented by the companies. And at the same time, there are probably commercial interests that don't make them want to do that. Now, in the case of the 2-dose recommendation also, WHO had called the companies to present data, looked at all data, suo moto cognizance type of thing. And then the 2-dose recommendation came from that. And then now the single dose thing also, they have had various meetings. So as I said, it's not yet been robust enough for them to switch to the 1-dose completely. And moreover, as I put it into the chat box, they have found some studies for the boys which are not supporting single dose, which doesn't make sense because the immunogenicity is actually the same. But anyway, that data is still pending. So that is why this 1 or 2 dose is still continuing in that respect.
Thank you so much for clearing out so many doubts. Thank you.
Dr. Jyoti Bhaskar, ma'am, are you there, ma'am?
Yeah, I'm there. Hi, Panch. Hi, Dr. Neerja. As always, your talk has underlined totally the importance of giving a single dose vaccination. And probably for all the private practitioners, I think it's an important one because we still many times give two, considering that as already discussed. But I would just like to ask you one thing, madam, that in many countries, as you say in Australia, they've already been giving for the last so many years. So if the child has been vaccinated by the age of 14 or let us say by 17, do we need later on to do any screening tests for them, or it has been decided that no screening if they have been vaccinated before 15?
No, they do have to have screening because none of the vaccines is covering all the types, not even the non-availant. So there will be the odd ones which will be left out. Then there is also the question of the HPV negative cancers, which is a question and which makes people say that HPV testing alone should not be the case. But anyway, that screening gives an opportunity for their checkups to be done as well. And then there will be some who may have breakthrough, or there may be some who got exposed already by the time they went to vaccination, etc. So right now the screening recommendations have not changed, but it is expected that they will become less frequent in time.
And among the screening, would we do an LBC plus HPV, or it would be just an LBC would be enough for the ones who are vaccinated?
So for vaccinated, they suggest that it should be HPV testing, but it's important to do the validated tests really, and not the open source PCRs, which can detect very few copies and which can also miss copies depending on which primers they use. So using one of the validated HPV tests is better because the lesions are going to be fewer and fewer. It is expected that the positive predictive values are going to be worse. The pathologists will have less exposure to lesions and their competencies are going to be at stake. So for various reasons, they say that after vaccination, it will be better to do HPV testing as the screening method.
Thank you so much. Thank you.
Thank you, ma'am. Dr. Deepti Naab, ma'am. Dr. Deepti Naab, ma'am, are you there? Dr. Divya Singhal, ma'am.
So, thank you for this very informative talk, madam. You've covered everything. Just take away messages. I wanted to clarify that either it's going to be a 1 or 2 dose. Still, we are stuck on that 1 or 2 dose from 9 years to 20 years of age. And it has to be a HPV 4 vaccination, mostly. That covers it. And after that, after 20 years of age, it should be a 3-dose schedule. Am I right, madam? I mean, for all of us.
No, after 20, from 21, it's 2 dose. Up from 9 years to 20 years, it's 1 or 2. And this basically WHO guidance is really for countries to decide which one they want to adopt. And India has adopted 1 as such. So after 21, it is 2 dose at 6-month or more interval. But if they are HIV or immunocompromised, then it is 3 dose.
Okay. Yes. So let's just stick to 1 dose till 20 years of age. I think we should be on the same page, all of us. Number 2 is regarding the side effects and the anti-HPV lobby that we have, which crops up now and then once again. So we should also have the same kind of thing against the anti-HPV lobby, that it has no side effects. That HPV vaccine has no side effects.
Yes, and if you have, like Dr. Taru Chaya had put a very nice message that my girls got vaccination and my daughter had a baby and all. I was thinking it's very nice, and it would be nice if they can just make short videos and put them out so that they can be, circulated further, and they can also reach the ears of people who are hearing the other side of the story. So a video can be a little bit more effective in that respect.
Yeah, because people get influenced by negative propaganda more than anything good happening. So
Yeah, and you can't blame people. अगर कोई आके कहेगा आपके बच्चा नहीं होएगा लड़की के, naturally they are going to get concerned.
Yeah. And the third thing was, madam, that once the HPV testing starts off at 30 years of age, and if a patient is HPV positive and she hasn't had a vaccine earlier, so of course we give her we go ahead and give her the vaccine. Is that clear to everybody? And you would like to say something on that?
So now, in fact, there are, earlier there was a lot of thing about this prophylactic vaccine, and it is not for therapeutic, and it is not for therapeutic even now. So it's not going to clear the current one in any way, but they say that the recurrence rates are less. There are a lot of trials on that. I'll be presenting that tomorrow. And so again, there are some which don't support that it helps, but many trials support that it helps, that it will reduce the recurrence rates in the future. One thing which we don't talk about much, but which I think is equally important, is the protection of CA vulva, which is also, such a rare but ghastly cancer. And to have that protection, even if it is not as much, even if it is like whatever 60% or whatever, is also, to my mind, a very useful one. To get all these side benefits that one is getting are also important.
Thank you, ma'am.
Thank you, ma'am. Dr. Sunita Arora, ma'am, are you there, ma'am?
Madam Leena is
Hello, ma'am.
Ma'am is Leena, ma'am.
Dr. Leena, ma'am, can say
Yes.
before me.
A very, very nice, absolutely comprehensive, ma'am. It was really wonderful, mesmerizing, and I was listening very intently. I just wanted to add a little bit to what Dr. Divya just was, clarifying again. So because then it's nice to get the message across. So as you said, it can be bivalent or it can be nanovalent. It's a choice of the patient. Is that the message?
Yeah,
that
I think if they are affording, they should definitely take the monovalent. If they are not affording, the quadrivalent is good enough from the perspective of cancer particularly, and even other things. Yes, it is also beneficial, very much so. But monovalent, if they can afford, is definitely the choice.
So regardless of the age, we can offer them, and there's nothing if they want to take the nonavalent, even if they are, say, 35 or 40 years of age.
Yeah. That is probably
Right.
even better to take nonavalent, because they may have been exposed to one or two of them, but they may not be exposed to all, so they can take it.
Secondly, if a lady comes and she's 51 and she wants to take that, what more do we say, apart from, of course, that she should regularly screen herself, like what we are offering everyone?
51, I doubt very much that it's of much further. By that time, menopause, the entire transformation zone has gone very quiescent. The risk that she will now get an HPV infection that will establish itself and cause a serious problem is very limited. So if she's got bags of money, it's fine, let her do it. But if she doesn't, I'm sure she can do better stuff than to put it over there.
And last but not the least, ma'am, what I feel is the pediatricians don't discuss all the things that we've been discussing on this platform time and again. They just say you've got to take this. And what I find even in my hospital is that they're way ahead of us in the numbers that they are vaccinating as compared to
Right.
us. We are answering their questions, we're clarifying so many things, and somewhere you see that there is a hesitancy when probably when we as gynecologists are talking to the I'm not talking about the young girls at 14 years of age, but I'm talking about the young adolescent population and the youngsters who are coming, who are sexually active, who are age 21, 24, 25, who are coming to us. So I feel the pediatricians
really right
have
about
upper hand in that.
Yeah, you're very right. And I think they have command a certain sort of a thing with the patient के भाई vaccines जो बता रहे हैं मेरी pediatrician ठीक बता रहे हैं. I had a very interesting experience in one talk show I was on NDTV, and the pediatrician had made a very good point, I thought, and he said that every doctor, regardless of their specialty, should ask their patient, have you taken HPV vaccine? And then the patient will get the feeling that this is something important. Wherever I go, people want to know, have I taken this vaccine or not? And it will reinforce the importance to everyone. I thought that was a very good message also, that we should, all of us, be asking patients, "Ye lagwa liya ki nahi?"
Yes, it's like, haven't you taken it? And so the patient feels, oh, there's something lacking. I didn't do that. So
yeah.
It's a positive reinforcement. Yes.
Dr. Bathla, here I just wish to ask you if the vaccine Gardasil 9 is permitted here for girls till 26 years, but I find gynecologists are giving left and right above the 26 years. To my mind, they should be following the laws of the land. They should not be giving Gardasil 9 for 26 and above till the time the DCGI clears it.
वो ये है कि it becomes off label, and then if there is anything, then you have to deal with it. But then a lot of off label stuff we do otherwise also. So I think it depends on the individual how much they want or think is important, and they must know that it is an off label if they are doing it over. Because this vaccination, the same vaccine is licensed in different ways in different countries. Gardasil 4 is not licensed for boys in India. It's licensed all over the world, used in so many programs, but they just haven't applied. They haven't given the data to the DCGI, so they cannot get that license. So, but in any case, as I said, how many women will be benefited after the age of 26 or max 30 years is another question altogether. But yes, it is off-label. There's no doubt about that. Madam is very right.
Because I think, the people are getting very smart, and litigations have started coming, that they have given me at 36 years. When it was for boys, it was only up to 15 years. So I think people should be very careful about it.
Yes, definitely.
Okay.
Ma'am, pediatricians are very proactive. In our hospital, we did a CME-like thing for our whole staff. Everybody was there. Even nursing officers were there. The support staff was also there. They are quite proactive, and I was, pleased to know that children who have completed 14 years and are not yet 15, they are getting. But because of the start of the campaign, government has been liberal enough that those children who become 15 within 3 months of start, that is after 28 February when this was launched, they will be given the benefit of immunization. So I think we must have regular conversations with pediatricians also. And, ma'am, as so many queries have been raised at this platform, same was the case. So many nursing officers, they came with query regarding infertility in HPV receiving girls and all this. So it is very good. We should discuss it more. And ma'am, I really like this idea कि आप कमरे के बाहर लगा सकते हैं. क्या आपने HPV vaccination लिया? I think that's a very good idea. Thank you, ma'am. Thank you for your wonderful presentation, ma'am.
I just wanted to say one thing. My son and husband both are pediatricians, and they are giving vaccination in the routine. When I told him, भाई मेरे को डाटा दे दो, तुमने जितने को दिया at least हम motivate तो करें. कह रहे no, हम तो routine नहीं लगा रहे. Nobody is questioning us, and it is so difficult for us to convince. We are going to schools, we are going to so many places to convince the school children, boys and girls both. And pediatricians are giving routinely. So I very much like this point. And now I'm taking his help to emphasize. And we are going to schools and we are trying to vaccinate the whole lot. So definitely pediatricians should help us in this. So it's very much needed.
Pediatrician तो मैडम ज़्यादा बोलते ही नहीं है. उनसे कहना कि मैडम आपने HPV वैक्सीनेशन नहीं लगाया, आप प्लीज बाहर अपना भी जरूर वैक्सीनेशन लगा लीजिए. बस इतना बोलते हैं.
Ma'am, I have a question on HPV testing. if you say PCR should not be done, then what should be writing? What should be looking at the lab where we are sending
What
the
we are
samples?
doing with PCR, even in the validated tests like COVAS, like Cepheid, like On Clarity, like the StruNat HR also now is there. And these are the main ones. Hybrid capture used to be there, it's phasing out. So these are the ones. So what happens with the open source PCR is, and we have seen this in our own lab, firstly, they're very subject to contamination. And the second thing is that PCR, as you know, can even pick up a few copies and amplify them. So there is a concept of analytical sensitivity versus clinical sensitivity. So if they are below a certain number of copies, the chance is that they will be cleared out by the system and they will never reach anything of significance. In hybrid capture, for example, the cutoff was 5,000 copies. Different tests have different cutoffs. So they will not report it as positive below that level. Other way also the problem is there if the primers are not sensitive enough. So there were the original primers which were called MY911. Then they were not capturing the very small broken fragments which may be there. So then they came out with what they call the pygmy primers, PGMY911. So they captured. Then there was the GP5+, 6+, which were the most sensitive. These were the ones which were first used in IARC, a very famous study by Wolboomers. What he did, he told everybody around the world, if you have any HPV negative cancer samples, send them to me. And then he did them with these very sensitive primers, and then came that famous paper that 99.7% of cancers are HPV positive, because even those who are not detected by routine are detected by those. So this PCR open source can err on both sides. It can, and I think both are bad because it's not sensitive. Sorry. You tell a young girl that you are positive. It's very bad. Recently, somebody told me a 25-year-old girl who was told that she's positive and every 3 months test karao. Sorry.
Ma'am, take a break.
Madam needs a break. Your throat needs a break now.
Being unmarried in a relationship, made to feel guilty and all of that.
Ma'am, I want to ask one more question. I found, in Hindi papers 2-3 times it has come that, this Arogya Mandir, something like 11 crores girls have been screened by VIA. And the government is trying to take a credit. The gynecologists could not do it, and these nurses are doing it. What is your say about that?
No, but nurses can do VIA. Usme kaun si aisi baat hai?
No. The question is, this is being promoted till the time this dedicated HPV diagnostic test is available. This has been encouraged by.
National program तो इन्होंने 2016-17 से बनाया हुआ है.
That's right.
To do the VIA. But the problem is the linkages are so bad. The positives don't get any triage, biopsy, treatment. So it's very confused. Maybe some are doing well. Now Dr. Radhika has started a program for Delhi. She is starting a program.
Quite some time.
30,000 women with HPV testing.
Okay.
She's in the Directorate of Family Welfare now, Dr. A.G. Radhika.
Yes.
So she is going to start a program for 30,000 women by HPV testing. I'm not sure which test they finally zeroed in on.
Okay.
So with these tests, mostly the 16-18 at least is identified. So you get that instant triage that these women should be treated, preferably in the same sitting, because they have very high likelihood that they will persist and progress. But in tests like On Clarity, you get even more detail about which type it is. And then you can get a prognosis. But it's a little more expensive, and I feel to do it for all people may or may not work. But at least for those who are positive, to check the persistence, to check clearance, tests like that can be definitely very useful.
Madam, when we had the VIA to begin with, it was because in a single visit, In a single visit, one could do the BIA as well as the treatment, whether through cryo or through thermoablation. So that was the idea of BIA. But in case one is going to do an HPV on them, that means that will entail another visit. She comes back with the report, and then the the action is taken on the report.
So there are some tests which are being called so-called point of care, which gave the result in an hour. So Cepheid is one of them, TrueNat is one of them. And in this, it's not exactly point of care, but in an hour you get it. It's a closed system. You just put the sample and the machine does the rest. So those can be used in some settings, but it doesn't always work. Japaigo did one study in Amethi, and they compared doing this TrueNat versus collecting samples and taking them to Lucknow for doing COBAS. And you know the TrueNat, because वो दो चार test at a time depending on the size of your machine, और वो कह रहे हैं एक बंदा पूरे दिन लगा ही हुआ है वो sample testing के लिए versus you collect and send. So that's also an issue. So in fact, what I suggested to Radhika was that if you have a place where the medical officer will do the treatment, then it's okay to do the point of care. अगर वहाँ पे point of care किया, but there's no one who is doing the treatment, then there's no fun of the point of care, which will just entail one more person. And where is the HR? That is also in short supply. So it's not a one size fits all, of course. But yes, and COBAS, now Karkinos had a very good offer, which they have extended till 31st December. They pick up the sample from you, they take it, and for 970 rupees, they are offering the HPV test and the reflex cytology for the HPV positives. So they can pick that up from you. Metropolis has some limited offer, so you have to get registered with them to get that 1,000 rupee rate. But they also do the COBAS for about 1,000 rupees. So there are various options for getting the COBAS testing done. If you have a high volume